Hello everyone, here we are with another episode on inflammatory bowel disease. We had already discussed something about inflammatory bowel disease, and this is part 2 of our podcast. So this is Dr. Riya S, MD Medicine, and we have with us Dr. Krishanu B, Cold Medicines Gastroenterologist, and we are now going to discuss about the management regarding diagnosis and treatment and other follow-up regarding IBD. Hello sir. So
Hello.
today starting with our part 2 of discussion. So last day we discussed about the disease, what the disease means, parts of involvement of the GI tract, and clinical features, symptoms that the patients can get. And today we are going to discuss about diagnosis and treatment majorly.
Right.
So for diagnosis of the disease, we have multiple modalities for initiating with blood test, few routine blood tests, specific serologic tests. So would you like to elaborate on them?
Okay. Good evening, everybody. And before starting this discussion, I'd like to take this opportunity to thank you to continue our journey in this New Year Eve. And I'd like to say hi to everyone and Happy New Year and wish health to everybody. Before this discussion regarding some diseases, I'd like to urge everybody to stay healthy and fit. Yes, now regarding the question, we have multiple modalities of diagnosis. We can divide the modalities in broad headings of clinical scenario, the background clinical scenario, endoscopic findings, radiological findings, and histological findings, along with the routine blood investigations as you have mentioned. So, in broad category, we prescribe for endoscopic tests like colonoscopy for diagnosis of IBD or inflammatory bowel disease. Some radiological tests in some cases like ultrasonography of our abdomen or some special CT scans, and in endoscopic procedure we take biopsy from suspicious areas or pathological findings, which we subject to histopathological or biopsy test, commonly known as biopsy test. So, along with clinical features, as we have already discussed, these three broad categories of tests help to diagnose IBD.
Okay, sir. So, would you like to elaborate a bit on the serologic test or the role of colonoscopy or endoscopy, or the role of radiological tests like CT scan or an MRI in diagnosis of?
Okay, I have got your question. Regarding serologic tests, there is no much definitive role of serologic tests. Previously, it was thought that some ASCA or ANCA antibody test, commonly called as ASCA or ANCA, these were tested to see whether they have some diagnostic or prognostic role. But as of today, there is no big role of these serologic tests. But yes, endoscopic or colonoscopic tests have a major role. They play a major role in diagnosing IBD, and often these are the first line tests. We prescribe colonoscopy as first line test when patients come with IBD symptoms like diarrhea, blood in stool, weight loss, anemia, pain in abdomen. So, in this scenario, we first prescribe some common blood tests, that is complete blood count, CRP, along with colonoscopy, and with or without some imaging, or as you have mentioned, CT scan or MRI. Now, in imaging tests, there are several modalities. As a primary screening test, we prescribe ultrasonography of abdomen. But if we get some suggestive finding in endoscopic modalities, then we go on to prescribe CT enterography or MR enterography to especially examine the whole length of our GI tract or intestine. And nowadays intestinal ultrasound, that is IUS, has come up as a very affordable and acceptable to patient modality as a diagnostic and monitoring test for IBD. And we have seen in our experience that intestinal ultrasound can supplement or can avert colonoscopic examinations in some cases in the process of follow-up when patients are unwilling to do colonoscopic tests, or patients are not totally fit to undergo such lengthy preparatory phase of colonoscopy and the procedure. In that cases, we can prescribe intestinal ultrasound, which is a very simple test, just like normal ultrasound. And last of all, but not the least, rather a very important modality is histological examination. The tissue we get in colonoscopic examination, we collect the tissue, we take biopsy, and the biopsy is subjected to histopathological examination under microscope, which is done by our pathologist friends. So these are the basic and necessary tests to diagnose IBD.
Okay, sir. Sir, some tests we have been seeing from a long time, and there are some novel tests that have come now after in studies they have shown good results. So, sir, what is your opinion on these novel tests, and how are they more advantageous compared to the regular investigation procedures that
Look,
we go through?
when the patient is coming for the first time with symptoms suggestive of IBD, like ulcerative colitis or Crohn's disease, then we have to do some conventional tests. These are blood tests, colonoscopy, some imaging tests, and histopathology. And when once diagnosis is certain and we are treating the patients, then we follow up the patients with the help of certain modalities, some certain diagnostic modalities. And one novel modality which has come up very strongly, that is intestinal ultrasound. It has gained much popularity because of its ease of access, because every hospital, every test center has an ultrasound machine, and nowadays we can do intestinal ultrasound with portable ultrasound machine also. So to mention, if you ask about one novel test that has come up in the management of IBD with a bigger role, that is intestinal ultrasound.
Also, it escapes the long
Yes.
procedure of
Yes,
preparation.
rightly said. Patient can escape the longer bowel preparation, and sometimes who are aged persons who have some other comorbidities like heart disease, kidney disease. For those patients, taking large volume bowel preparation is difficult. So in that case, we had to admit them in hospital to avoid fluid overload or excessive intake of fluid, and we sometimes use enema or parectal medicines to prepare the bowel. Now, in some cases, I'm not saying that in all cases, this intestinal ultrasound has supplanted this colonoscopic modality, which requires minimal patient preparation and minimum time, and the cost is also at par with the conventional modality. So, in my opinion, intestinal ultrasound is one of the novel tests which will go far in the management of IBD.
Okay, sir. So now if we come to discussion on the treatment part, so coming for treatment of both ulcerative colitis and Crohn's disease, there is one supportive treatment that we give to help the patient with the symptoms, and there comes the definitive management of the problem.
Right.
So we know we give there are induction for the remission. There are induction therapies and maintenance therapies. Generally, some drugs are given to quickly act, start the remission process, and then maintenance is done. And a lot of agents are used. So, sir, would you like to detail about the agents used for treatment of conservative management of IBD?
Yes, in this scenario, I'd like to elaborate a little bit about what induction is and what a maintenance is. These are the terms we commonly use for treatments given in IBD. Induction means when patient comes for the first time, or subsequently when there is an increase in symptoms, then we try to control their symptoms quickly with some drugs at a higher dose or at a frequent interval, and some specific drugs. This is called induction therapy, and this induction therapy goes for a shorter period of time, followed by once the patient achieves remission. That means patient is symptom free, there is no blood in stool, patient has less diarrhea, and he is getting nutritionally developed. Then we maintain the remission phase. That means asymptomatic phase is maintained by certain drugs. That is called maintenance of remission. Now this maintenance of remission therapy is longer, and as of today's time, indefinite period maintenance is the rule. So this is about induction of treatment or remission and maintenance of remission. Now there are certain drugs, as you have mentioned, or medicines which are used to induce remission or maintain remission. Most commonly, the first line drugs for IBD are 5-amino salicylic acid. These are oral tablets, and azathioprine group of drugs, methotrexate, cyclosporin. These medicines can be given orally, and there are some injectable medicines also. These are called biologics like infliximab, adalimumab, and other biologics like vedolizumab, and these are the group of injectable drugs. And for easy understanding, we generally use if the patient is symptomatic with lesser severe symptoms, then we usually use step up approach. That means we start with them firstly with oral drugs, and then if the symptoms are not controlled, then we switch on to biologics or hard class of drugs. But when the patients present with severe symptoms, patients are malnourished, they have lost several pounds of weight, they are having 8-10 times of diarrhea, or having features of intestinal obstruction, that means narrowing of our intestinal lumen, or when the patients are young, presenting for the first time at a younger age, then these patients tend to have severe disease, and they need to be treated aggressively from the very first. And in that cases, we use these injectable group of drugs as the first line of drugs. So these are the treatment strategies. Both oral and injectable medicines are used, but we take different strategy according to the symptomatology, age, gender of the patient in an individualized way. So, in a nutshell, IBD management is not very easy. It is complex, but these are very effective management.
Okay. So often there is need of steroid in
Yes.
management of IBD. So
Yes.
would you like to describe?
Yes, steroid is one of the first line drugs for inducing remission in IBD patients, and the advantage of it is it can act very quickly, and it gives time to the other drugs to take over, so that maintenance can be done with other group of drugs. And steroid drugs are very cheaper, and they have shown benefit over other drugs, some mortality benefits also in severe cases, like acute severe ulcerative colitis. When we treat these patients with steroid, they can avoid surgery. So steroids are very cheap, easily available, and used for shorter duration, but very effective. So it is considered as one of the first line drugs in inducing remission.
Okay, sir. So, if a patient becomes steroid dependent, sometimes we try to taper off the steroid because of long term
Right.
use. Steroids can have disadvantages, adverse effects on the patient.
Yes.
So, are there some novel steroids with minimal
Yes.
side effect profile?
Yes, that is a very important aspect you have mentioned. Steroid cannot be used for longer time. We divide steroid as systemic steroids and steroids with localized actions, that is actions on the intestine only. So these novel steroids are steroids with localized actions like budesonide. So systemic steroids are prednisolone, commonly marketed as Visolone or Omnacotil name, and budesonide is locally acting steroid. So in steroid dependent patients or those patients who have contraindication to steroids, like suppose the patients are diabetic, patients are hypertensive, they have history of thromboembolism. So in these patients, or the disease is localized and not very much severe, in those cases we can use budesonide group of drugs so that they are not absorbed very in a very larger amount, and they pass through the intestine, and while passing they act on the diseased areas.
And they have a controlled release.
Yes, they have a controlled release. So we choose preparation according to the disease site severity and transverse mural involvement. Mural involvement means whether the disease is involving muscle or whether the disease is only involving the luminal mucosa. So these are the different preparations of steroid. And one thing you have rightly mentioned, that what to do in case of steroid dependent or steroid resistant disease. In that cases, we have to supplement steroid with azathioprine or methotrexate kind of drugs. And in some cases, if these are ineffective or contraindicated, then we have to switch to biologicals, which are novel, comparatively newer groups of drugs. And there are some small molecules like tofacitinib, some like upadacitinib, like astikinumab. These are newer groups of drugs which can be used. So there are nowadays there are multiple options to treat patients who are steroid dependent or not responding to steroid. So we don't have any dearth in armamentarium in treating IBD. There are ample groups of drugs apart from steroid to treat IBD.
Also, sir, tofacitinib can be used as oral drugs.
Yes, that is a very big advantage, and the onset of action is very quick, and it can be maintained for long.
So, sir, while a patient is on treatment, how do we monitor the progress?
After starting treatment, after starting the induction treatment, we have to monitor the patients very frequently. Suppose in case of ulcerative colitis, which involves only colon, once we start induction therapy, we monitor the patient 2 weeks apart. So every 2 weeks, for up to the completion of induction therapy, patient has to visit hospital or his doctor with some blood tests like complete blood count, CRP. These are the common blood tests. And once the induction period is over, then we usually choose to follow up them at a longer interval, like suppose initially 1 month, then 2 months interval, then 3 month interval. So this is the follow-up protocol or method to better control the IBD symptoms.
So, is there any role of surgery?
Yes, surgery has an important role, and we have seen that in 20 to 30% cases, if you follow these patients up for a period of 10 years, then 20 to 30% patients will require surgery. So, out of every 10 patients, 3 patients may require surgery at a longer term. And there are, before surgery, there are some endoscopic approaches also. These are tried before surgery nowadays because they are less invasive than surgery, requires lesser hospital stay, and they can save a larger length of colon, because IBD involves the colon, and especially Crohn's disease, which can involve anywhere from mouth to our anal canal. So we have to keep in mind a perspective of saving the longer length of colon. So in those cases, endoscopic therapies play a major role.
Sir, and in course of treatment only, is there any role of particular nutrition therapy? And would you like to brief on role of prebiotics and probiotics in the management of IBD? Previously, we had discussed about the role of gut microbiota
Right.
in pathogenesis of the disease.
Right.
So, what is the role of prebiotics or probiotics in treatment?
Yes, that is a very important aspect. What is the role of nutrition? We know that IBD is an autoimmune disease, and it is a catabolic disease. So, people with IBD, especially those who are untreated, tend to lose weight very rapidly. So, usually they tend to become malnourished. So we prescribe them a diet rich in nutritious, elements, protein-rich diet, and in some cases we restrict them from taking fibers, like in Crohn's disease, where there is a chance of luminal narrowing when patients presenting with symptoms of intestinal obstruction, or when there is a suspicion or established narrowing of intestinal lumen, then we restrict them from taking fiber rich diet or small nut like peanuts, or this kind of foods are restricted.
Food which can absorb water.
Yes, food which can absorb water and
And
swell
swell.
up, and while passing through a narrower part, they can obstruct and increase the symptoms. So, in general, we prescribe IBD patients to take nutritious, balanced diet, rich in vitamins. Often, we supplement multivitamins and calcium, and ask them to take food rich in proteinaceous materials.
Yes.
And also about probiotic, there is no much proven role of probiotic as a therapeutic modality. Yes, there is definite role of disordered microbiota, intestinal microbiota, in the pathogenesis of IBD, but as of now we do not prescribe prebiotics or probiotics as a treatment modality of IBD.
Okay, sir. Sir, are there any differential diagnosis for IBD symptoms, diseases which can mimic IBD? Or
Yes, in India, intestinal tuberculosis. This is one of the foremost differential diagnoses for Crohn's disease, which also produce obstructive symptoms, which can also produce diarrhea, blood in stool. So, intestinal tuberculosis is one of the most important differential diagnoses, and in some patients, when there is a history of previous bowel surgery or abdominal surgery, so these surgical scars can mimic symptoms of IBD. In older subjects, when the patient is especially suffering from coronary artery disease or atherosclerotic heart disease, then these atherosclerotic ischemic events may mimic IBD. Suppose a patient has got some radiation therapy over abdominal or pelvic region. So this pelvic radiation induced stricture or diarrhea can mimic IBD. And as we are living in a tropical country, there are some infection. There are infective causes which can mimic IBD, like common diarrheal infective agents can lead to diarrhea as well as blood in stool. So these are the most common differential diagnoses which we generally keep in mind during treating IBD patients.
okay, sir. So we had a very good discussion. So will you please summarize the entire IBD topic for benefit of the viewers?
Definitely. So for treating IBD patients, when if somebody is coming with pain in abdomen along with diarrhea, blood in their stool, weight loss, anemia, some joint pain, or some foreign body sensation in their eyes, some skin conditions. These are clinical evidence of IBD. And in these patients, we generally prescribe some, as the initial diagnostic modality, we prescribe some blood tests, colonoscopy with or without endoscopy, some imaging tests like CT scan or ultrasonography, and histopathology as a supplementary test of endoscopic procedures. Firstly, we treat IBD patients with oral drugs or injectable drugs, and it has been seen that the symptoms are controllable of more than 80% cases in IBD patients. So there are so many medicines to treat IBD. In the long run, 10 to 20 years, about 20 to 30% patients will require surgery, and these patients usually require a prolonged follow-up, and the prescribed medicines should not be stopped without specialist doctor's consultation. So this is IBD in a nutshell.
Okay. Thank you, sir, for such
Thank
a
you.
lucid discussion about IBD. I hope viewers will find it helpful because this is not a very much discussed topic but
Yes.
needed this useful discussion.
Thank you. Thank
Thank
you
you.
very much.